To be back at UNC. It's been a long time since I've been here. So I'm presenting this work today actually on behalf of a former PhD student from Temple University. She unfortunately couldn't be here with us today. So Dr. Miriam Wamsley, she's a respiratory virus epidemiologist with the Pennsylvania Department of Health. So if you have very complicated modeling questions, you might want to email her as opposed to me. So what was Miriam interested in looking at? She was really interested in using epidemiologic and spatial temporal methods to investigate the extent to which rainfall and drought, as well as exposure to domestic well water, contributes to reportable enteric diseases in Pennsylvania. And so she was really interested in private wells, which is the reason we decided to work together. This is a map of the state of Pennsylvania in the northeastern part of the United States. And you can see all those little blue dots there are all private wells. And so there's a high density of private wells. And we were wondering, well, is there increased incidence of disease associated with drinking untreated private well water? So in terms of what we know about the impacts of climate and diarrheal disease or enteric disease, there's still lots to be uncovered. And so a recent systematic review identified that antecedent conditions impacted this effect of rainfall on enteric disease. There's been work done in Australia looking at cryptosporidiosis and drought. There was relationships found there. And some work done in Georgia looking at salmonella and prior rainfall events as well. Also from some systematic reviews done by my research team, we've identified that private wells is an area where we don't really know what the burden of disease is globally. And then pathogens that we find in private wells are an emerging contaminant of concern. We also did a review of what is the epidemiological evidence that groundwater contributes to enteric disease globally. And this old review found 649 published groundwater outbreaks globally, mostly from public groundwater systems. And there was a series of organisms that were discovered when we actually measured the water quality. So sometimes under outbreak or non-outbreak conditions. And so they include viruses, bacteria, and protozoa. And for the focus of today's presentation, some of the reportable enteric diseases in Pennsylvania are salmonella and campylobacter, which we find in groundwater, but they're also foodborne pathogens, and protozoa, which are largely waterborne, cryptosporidium and giardia. So we're going to focus on those four pathogens today. So the first aim of this research was to determine the effects of rain and drought on weekly counts of reportable enteric illness, so salmonella, campylobacter, giardia, or cryptosporidium in Pennsylvania between 2010 and 2019. The data sources we used are we obtained weekly case counts of data from the Pennsylvania Department of Health for salmonella, campylobacter, giardia, and cryptosporidium between 2010 and 2019. We then used weekly regional precipitation data as well as weekly Palmer Drought Severity Index data, which was divided by 10 climate regions across the state of Pennsylvania. We also accounted for season. And so our methods were an ecologic study design using the entire study population of the state of Pennsylvania, which is roughly 12.8 million people. Our analytic strategy was a zero-inflated negative binomial model with county population as an offset. And in order to test what time lags we wanted to use, so in essence, when we found our exposure to when our illness happens, we use a cross-correlation, to identify the top four lags. So for our lags, for cryptosporidium, giardia, campi, and salmonella, you can see there's 4 to 5 lags listed, so I lied. We sometimes use 5 if the cross-correlation had a tied value. We then chose the top 5 lags to test for using our models. So you can see the time lags vary considerably from as little as 3 weeks all the way up to as 24 weeks. So what were our results for AIM 1? In terms of rainfall and enteric disease, we found for campylobacter that rainfall 10 weeks prior was associated with an increase in cases. And so this was statistically significant. So for every 1 centimeter increase in rain, we saw a 1.8% increase in cases. For salmonella, rainfall 4, 5, and 12 weeks prior was associated with increases in cases. And so for a 1 centimeter increase in rain, we saw anywhere from a 0.1 to 1.5% increase in cases, depending on which lag we were looking at. For giardia, we found that rainfall 12 weeks prior was associated with an increase in cases. So for every 1 centimeter of rain, we saw a 0.2% increase in cases. And then for cryptosporidium, interestingly, we found no relationship between rainfall and cases. Now, when looking at drought and enteric disease, we looked at Campylobacter. We found an increase in this Palmer Drought Severity Index, which actually, the higher that value goes, it infers like prior wetness. So the ground is more wet. The environment is a wetter, in a wetter state. And so at 10 and 11 weeks prior, we saw an association with increased cases associated with this drought measure. And so for every 1 unit in this PDSI measure, we saw 0.9 to 1% increase in cases. And this was the only pathogen where we actually saw an interaction effect with rainfall, which is kind of getting at what was seen in the paper actually by one of our colleagues here, that there's kind of complex relationships that might be occurring in between rainfall and drought conditions. Salmonella, we found no relationship between PDSI and cases. For Giardia, we also didn't see a relationship. And then for cryptosporidium, we saw an increase in the PDSI at 3, 14, 17, and 24 weeks prior was associated with an increase in cases. So moving on to aim 2, our aim was to identify clusters of reportable enteric diseases, so Salmonella, Campylobacter, Giardia, and cryptosporidium, and determine whether those clusters were associated with drinking water source or presence of karst geology in Pennsylvania. So that's like a very vulnerable geology for those who aren't familiar, vulnerable to contamination. And so again, we used an ecologic study design. Our study population was the same. We used a cluster analysis at the zip code tabulation level using StatScan to do our cluster analysis. But then we did a regression analysis at the county level using a zero inflated negative binomial model to assess the relationship between the cases and the proportion of the area not served by public water. So essentially, area not served by public water we assumed is served by private wells. And then we looked at the relationship between cases and the proportion of area underlain by karst, if there was a relationship between the area not served by public water. So we only tested that if the first held true. So the data sources again were our weekly case counts of Salmonella, Campi, Giardia, and cryptosporidium, the proportion of area not served by public water systems, as well as the proportional area underlain by karst geology. And so what did we find? I'm going to walk you through these maps. We have a few of these color maps here. And so for those online, pay attention to kind of the top right purple corner. I'm going to use my pointer. So these purple area means high incidence of disease and a high proportion of area not served by public water, or a high proportion of people likely on a private well. And so you can see the areas of the state in the middle in purple are kind of a higher rates of illness that also are corresponding with higher rates of folks not on public water supply. And I want you to kind of pay attention to that shape, that kind of rounding shape, because it'll be interesting when we look at the karst map. So you see Salmonella, you can see the kind of the darker purple, darker green. These are the cases where cases are overlapping with no public water supply. Again, cryptosporidium, noticing this same pattern kind of around this curved area. And then Giardia, you can see it's a little bit of a different pattern. The purple is kind of more sporadic in different parts of the state. Now this is a map of the karst geology. I tried to overlay it on the other maps, but it was kind of very messy looking. But you can kind of see this kind of curved area where we see the karst that's also overlapping with those areas of private well water users. So what did we find when we did our regression analysis? We found for Campylobacter an increase in the proportion of the quartile area not served by public water, and the area underlain by karst was associated with an increase in cases. So basically for every increase in quartile area not served by public water, we saw a 29% increase in cases, and then for karst we saw a 21% increase in cases. For Salmonella, we actually didn't see any relationship between public water and karst geology and Salmonella. For cryptosporidium, we did see this relationship between karst geology as well as public water, and so for every increase in quartile area, we saw a 25% increase in cases of, for the public water supply, or lack of public water supply, and 36% increases in cases for those underlain by karst. And then Giardia, we saw this relationship with private wells, but no relationship with the karst geology, which you can kind of see on that map. It wasn't really overlaying, so there might be something else at play. So in conclusions, rainfall was associated with cases of Giardia, Campylobacter, and Salmonella at a variety of lags. There was a positive association between PDSI and cases of Cryptosporidium and Campylobacter. Private wells may be contributing to enteric diseases due to Campylobacter, Cryptosporidium, and Giardia in the state of Pennsylvania. And the occurrence of karst within the county was associated with Campylobacteriosis and Cryptosporidiosis. Future work should include investigation of these complex climate relationships with factors such as drinking water source, local geology, presence of contaminants like combined sewers, agricultural activities, recreational water use. And this will help us better identify waterborne transmission pathways so we can identify interventions. And so with that, I just want to acknowledge the funding, and the data was provided by the Pennsylvania Department of Health.
Thank you very much, Heather. Any questions for Heather? Okay, one. Any more questions across the room? Okay.
You go first. No, you go. You go. I thought you raised your hand first.
I've got the climate expert about to ask me a question.
This is great work. This is great work, Heather. Thank you. I was just curious about the lags, and they're pretty long.
Yeah, I knew you were going to ask. Someone was going to ask that.
So I'm just curious about your explanation, and then I have another question. What would be the advice to private well users that you could give them?
Okay. Advice for private well users in Pennsylvania, I say treat your well for microbes. Full stop. That's pretty much what I tell everybody. This table is maybe a bit busy. Oh, you might be able to see it. So yeah, we looked at the biological plausibility of these lag times. And so I didn't mention it in my presentation because it's so fast, but we had date of stool sample collection. So then you have to assess, what was the time to seek care and what's the transport in the environment. And so actually we kind of built this. Well, actually these are all very biologically plausible lags, and so if it's a 24-week lag, Cryptosporidium, for example, it can take 0 to 90 days for someone to seek care and submit a specimen. And then, so when you add that together with the incubation period, you can end up between 2 to 110 days before you've got that kind of lag period from time of exposure. So it could be groundwater, it could be produce contamination, it could be a lot of different things. So we don't really know the mechanism, but I think they're still biologically plausible. Yeah.
Yeah, really nice question.
Sorry, just want to.
Is that okay? Yeah, nice presentation, Heather. Yeah, I really like the question too, Karen. And I guess, building off of this idea of looking at these case data and underreporting of these things and how you think that might be biasing your findings. Are there certain populations, right, that might be more likely to go to a health? I mean, I don't know how often everyone in this room goes to a health department if they have, something like a GI illness, and how that might be, do you think that you're underestimating the effect given where you think underreporting might be happening, or overestimating, that sort of thing?
Yeah, that's a great question. I would say under-reporting is a huge problem with all enteric diseases. So I would say this is an underestimate of what's actually out there in the environment. And given this, if it's really related to private wells, the sporadic nature of contamination and people reporting cases, we're going to be picking up a lot of outbreaks also. But this is also sporadic disease when we've looked at the full data set. But it's definitely going to be underreported, and people who can afford to seek care and can go to the doctor are going to more likely seek care. And I'm pretty sure I do this with my students. I'll ask anyone at GI in the last year, how many of you went to the doctor? Probably none of you, and then we lost you all to the surveillance system, right? So. Yeah.
And so, so you think that would overlap? People that are underreporting are also more likely to use private wells? Are you thinking?
No, that's harder for me to say, because also the demographics of people using private wells in Pennsylvania are just very complicated. My student did a project on that. So there's people that are very socially vulnerable, and then there's people that are very affluent. And so I'm not entirely sure we can untangle that, but it's a very good question.
Yeah, because I think I was wondering how the underreporting might be impacting the magnitude of effect that you're finding.
Yeah, I think in terms of specific, and I think it's probably interdispersed. It really depends because, the population. think
I had a
Christine.
question about risk communication.
Yeah.
So you saw the higher risk of enteric disease for the karst aquifers.
Yeah.
Is there information given in areas where karst aquifers are predominant for people to consider treatment of their water?
No, there's nothing. And so this is one of the things we were talking about. We work with pediatricians in the state now, and we've been doing webinars with them to try and explain, like, these are the more vulnerable areas, ask questions about kids on private well water. So some of them already asked because of fluoride, and then they now will talk about enteric disease. But yeah, there's not a lot out there, and the state health department is starting to do a bit of more outreach with primary care physicians, because I think that's a way into that population. But it's, yeah, no one's done that yet.
Because normally you would get alerts if there was E. coli, but then these are private wells and they're not regulated. And so
Not
it becomes
regulated at all.
tricky.
Yeah, exactly. Yeah.
Right. Thank you, Heather.
Thank you.
The one. Okay. So next we have Kelly Endres. Here, 10 minutes.
All right. A lot shorter. Hello, everyone. Thank you so much for coming to our presentations today. We have some really interesting stuff going on in this session. So my name is Kelly. I'm here on behalf of myself and then also a colleague, Dr. Alan Washinko, who's with our partner, the Catholic University of Bukavu, who is my co-author on this work. So today I'll be talking about a program evaluation we did using both quantitative and qualitative methods, looking at a case area targeted intervention to reduce cholera in the Eastern Democratic Republic of the Congo. And we did this work, like I said, with the Catholic University of Bukavu, the DRC Ministry of Health, and then with support from the CDC. So individuals living in close proximity to cholera patients, we know, are at an increased risk of subsequent cholera infection. With a recent study, in fact, showing that individuals living within 20 meters of a cholera patient are at a greater than 16 times higher risk of developing a cholera infection than the general population in the week following that patient's hospitalization. So we can see that interventions that would target this period can have a very large impact. So what is a case area targeted intervention? These are CATI, or also called CATIs. They're recommended globally as a rapid intervention to reduce cholera transmission in hotspots where WASH interventions are delivered within a high-risk radius around a cholera patient household. So these generally include a package of WASH interventions, including hygiene promotion, hygiene kits, active case surveillance, household disinfection spraying, water source treatment, and sometimes antibiotic chemoprophylaxis and oral cholera vaccine, though those two are still being researched and are certainly not always delivered. And given that the content and delivery of CATIs can really vary substantially, more research is needed on different CATI packages that are delivered and then the hygiene materials within them, especially in relation to the WASH behaviors that would be highlighted during the hygiene promotion and promoted with the hygiene kits. So beginning in 2020, CATIs were implemented in Eastern DRC to aid in cholera response efforts. And we conducted our study to evaluate these existing CATI programs that were being delivered between December 2022 and April 2023. So we really wanted to build evidence on the effectiveness of these in promoting WASH behaviors and then the successes and challenges of the existing CATI delivery in the DRC. And again, we did not conduct our own CATIs as part of this effort. We were evaluating some that were being delivered in the area. So this slide on the right here shows a map of the DRC, and then South Kivu, the bottom highlighted province, is where we did our work for this study, specifically in two sites in Bukavu, which is a large, more urban city, urban for the DRC, and then Katana, which is a rural area along the shore of Lake Kivu. So the CATIs that were delivered that we were evaluating so what would happen is once a suspected cholera patient arrived in the health facility or in a cholera treatment center, the CATI team would be deployed to their household, where first the team would perform the household disinfection and then provide a hygiene kit and a short hygiene promotion message to that household. Then they would go to households within a 50 to 100 meter radius around the cholera patient household, conducting generally a short door-to-door hygiene promotion session and distributing the hygiene kit. Generally, the hygiene kit included chlorine tablets, hand washing or soap for hand washing, ORS packets, and a jerry can. Sometimes a hand washing station with a lid and a tap was also provided, but this was generally only the actual patient household. And then door-to-door promotion was followed by a group session where you'd have all of the households in the radius invited to participate, and then the wash behaviors were further promoted. So this would be water treatment with chlorine tablets, hand washing with soap, safe water storage, and food hygiene behaviors. And the delivery certainly could vary based on the conditions of the area and then also the availability of the materials at the time the session was delivered. So we had two different components in our evaluation. This included 12 CATI and 12 control areas, with 6 of each in our rural site and in our urban site. So for each area where CATI was delivered, we then added a control area, which was defined as an area that had not received a CATI in the past 2 years and were greater than 1 kilometer from an area that received a CATI in the past month. And then to assess the CATIs, we completed, like I said, both the quantitative and qualitative evaluation within 3 weeks of when the CATI had been delivered. We conducted unannounced spot checks, which these were looking at the use and presence of the wash materials, and then we did structured observation for hand washing with soap at food and stool related events. And then we had 41 different semi-structured interviews with the cholera patient households in the CATI villages, CATI implementers, and then certain stakeholders. Okay, so now our results. So from the spot checks, we first saw actually a little higher soap presence in the control area than the CATI area households. This was pretty similar between both groups. We saw a significantly different presence of chlorine tablets, with none of the control area households having chlorine tablets present, but over about 3/4 of the CATI households having these present. But interestingly, we saw really low stored water-free chlorine concentrations at that greater than 0.2 milligrams per liter, either suggesting that households were not using their chlorine tablets at the time that we tested the water, or that they were using them for other purposes. And then we did see ORS present in about 2/3 of the CATI households, but none of the control households. We, across the board, saw very low hand washing in both our CATI and control group, not only just hand washing with soap, which was actually a little bit higher in the control group, but basically non-existent. And then we also looked at hand washing with only water, in case there were a lot of households that didn't have that soap present, and again found this to be very low. And this was at stool and food-related events. So the results from our interviews, these ones are specifically with the CATI recipients, and we had a ton of findings from these, so I'm just pulling out some of the most important ones that we wanted to share with you. So first of all, we saw that, perhaps unsurprisingly given our spot check findings, chlorine tablets were used for multiple purposes in the household. So we had recipients talking about using these for bathing, for washing, especially for bathing. One participant talked about using these for dermatitis. We also saw a lack of understanding on the purpose of ORS, with some recipients discussing that it could be preventative and not just as a treatment. We also heard some discussion about the need to further engage community leaders in the delivery of CATIs. And then, even though the oral cholera vaccines were not delivered as part of the CATIs we were evaluating, to be clear, we decided to still ask about this as part of our interviews. And we found that recipients actually reported confusion on the cholera vaccine, with some saying that the delivered vaccines they thought were faulty, or that they completely protected from any cholera infection in the future. And then the results with our implementers, we had 2 main things to talk with you here. So first, we saw a shortage of chlorine tablets and soap for distribution, again, which we kind of saw through our quantitative results, talking about when they were going to deliver the CATIs, they didn't have some of the materials available to bring. And then that actually some households declined to participate in COTI activities, kind of citing a lack of trust in the delivery of the COTIs. With, you can see in this quote, one implementer actually kind of summarizing what some people were saying, that, oh, these things come from white people, we don't want them, we don't want our houses sprayed for the disinfection. So to summarize our findings, first of all, again, we have very low hand washing with soap and chlorination of drinking water among our COTI recipients, which was similar to the control areas. We really saw a lack of understanding on the use of chlorine tablets and ORS. We saw an insufficient supply of the chlorine tablets and the soap for distribution. We saw that some households declined to participate in the activities. And also the belief that if someone was taking the cholera vaccine, the risk of cholera was eliminated. And of course, our work wouldn't be as useful if we didn't have some recommendations from the findings that we had. So we really wanted, or we really would recommend further development and to implement COTIs with more engagement of community stakeholders to improve acceptability. To develop COTI wash modules using more theory-driven and evidence-based behavior change modules or methods to, because if we're delivering these hygiene promotion messages, it's really important when we're delivering them in a way where people will then take in that message. And of course, even if COTIs are delivered without a vaccine, to emphasize that the cholera vaccine does reduce the risk of cholera, but this is not eliminated, which is why these preventative wash behaviors remain important. All right, and so my acknowledgement, again, I said we have a ton of different people who were important in this work, from the Catholic University of Bukavu, the DRC Ministry of Health, and then my colleagues at Johns Hopkins. And again, to thank the CDC for the funding for this work. Oh, and we have there we go. We have a side event tomorrow just to call out in Mountain Laurel on some of our other work that we have going on in the DRC. And then questions. And I realized while I was sitting here, I forgot to add my email, so please come talk to me after and I can give that to you if you have any questions. So thank you.
Thank you, Kelly. We've got 4 minutes for questions, so just
Great.
just go around the room. If you've got any questions for Kelly. One.
Yes, please.
Okay.
Can you hear me okay, please?
I think for
Okay,
online, yeah.
Thanks very much. Nice presentation. Just a question about you know, pretty weak results in terms of implementation, which can vary by the implementing partner. One question is just on the timing of when you visited households versus how long they're given tablets for. So were they given 1 month and you went in 2 weeks, or was it close to the time where they may run out? So the timing of when you visit can impact what they have left over. And then the second question is, what feedback did you give to the implementing partner to improve actual implementation? This is what they need to hear. If they're not doing it themselves, you've done that for them.
Yes. Yeah, so we visited, I think the average was 14 days after the COTI was delivered, and I believe that they were given materials for 1 month, though again, seemed like this varied based really on what they had available when the COTI was delivered, and it was hard to pin that down exactly. But we did see that a lot of households, I think it was 75%, had chlorine tablets present when we visited, so they still had chlorine tablets there. And then in terms of what we told the implementing partners, we did bring this presentation and our publication and additional information to them, gave them our recommendations, and we're kind of going to see what they decide to do with that. Because again, it's hard when you've put a lot of work into delivering something to see that the results haven't been as effective as you might want them to be. So.
We've got time for more questions.
Thanks for your presentation. I was curious if you could talk a little bit about on the implementation side of the caddies and what that experience was like for the implementers. Sort of what challenges were they having maybe on the initial delivery, and if you made any sort of recommendations on that end as well.
Yeah, of course. So we were able to talk, like I said, with some of the different implementers who had gone out and done the work. And so I know, especially in our rural area, of course, they had some issues accessing areas, whether that was the conditions of the road or there is some instability in the region. And then they really talked about going to the households and sometimes having trouble convincing people, I think especially with the disinfectant spraying, to participate in the activities. And then the big one that people often mentioned was the availability of the materials. So just not having necessarily what they needed to deliver what they wanted to deliver. So those were really the main things. Yeah, please.
Thank you. How prevalent was, thank you very much for the presentation. How common was cholera in this group, in this communities? And the other question I have is, do you know if they practice, what's maybe called, I don't know what they call it, their communal hand washing before eating?
I do not know off the top of, I'm getting a nod that they do the communal hand washing before.
Or won't put their hand in the basin, like you were talking about yesterday, yes.
Okay, so yeah, I did not know that because unfortunately I wasn't.
And is that part of the catty?
During the Kati they deliver, or they have the session where they have talk with everyone, and I think they do the practice of showing hand washing, but I don't know about. Okay, yeah, so I wasn't able to actually, unfortunately, observe any of the Katis as they were delivered, because when I was in our study site, it was at a different time.
And then has insecurity there.
Yeah, there's some issues with insecurity, unfortunately. And then your first question?
Prevalence of.
Oh yeah, so I don't remember off the top of my head what the prevalence was during this time, but it is endemic in the region, and they have ongoing outbreaks.
Yeah, so it's a cholera endemic area. They have cholera cases all year long. And
Yeah.
I did see some of the cotis being delivered, and they talk very briefly about the communal hand washing and tell people to pour the water rather than putting their hands in the container. But we can see that hand washing with soap practices were extremely low. And I wanted to also say again, the NGOs that implemented the interventions, we did meet with them, highlight the challenges. We're currently expanding this work to North Kivu, to internally displaced persons camps. Because COTI is an approach that's used across DRC for cholera control. So evidence is really needed on whether this approach is effective or not.
Yeah, thank you so much, Christine Marie.
Thank you.
Okay, thank you so much.
Yes.
Okay. Should I just use this or the pointer? If you want to. I don't think I need the pointer. Okay. All right. Let's see.
Yes. All right. Good afternoon, everyone. I'll echo Kelly's thank you for coming to this talk. I know there's a lot of other interesting things going on right now, so we appreciate you being here. I'm excited to present this work on the association between drinking water quality and access in the infant gut microbiome among Mozambican children. And I would like to verbally acknowledge up front, because I mistakenly left an acknowledgement slide off, all of the collaborators on this work at Emory, the University of Washington, the National Institutes of Health in Mozambique, the local water utility, and many partners, staff, students, and our study participants. So first, I want to just walk you through why we care about this question. So the gut microbiome refers collectively to the trillions of microbes that live in our gut that have important functions both within the gut related to pathogen acquisition and clearance, and beyond the gut, we now know how it's related to neurological disorders, metabolic diseases, and kidney health, just to name a few. And particularly in early life is a window of opportunity for microbiota modulation, but also it's incredibly sensitive to environmental exposures during this time. So exposures as early as mode of delivery, so birth by cesarean section or vaginal birth, are known to impact the gut. and a variety of postnatal factors such as diet, animal exposures, and antibiotic exposures also have been shown to impact the developing gut microbiome. But one thing that isn't considered, particularly in studies on diet, is drinking water and how drinking water quality and access might affect the gut microbiome. So what do we know about drinking water and the developing gut microbiome? Not much. There are 2 studies that we know of to date that have looked at this relationship. The first evaluated the impact of this drinking water chlorination intervention on gut microbiome composition and resistomes in Bangladeshi children, and found that there wasn't much of an effect by chlorine specifically, but they didn't look at other measures of water quality and access. And the second paper down here didn't explicitly look at water quality. They were more focused on diet, but they did include some measures of water quality, and had this interesting and compelling conclusion in the paper based on their very preliminary findings that domestic water source may be an underappreciated determinant of microbiome acquisition, particularly in infants. So with all that said, the objective of this work was to assess if and how drinking water quality and access is associated with child gut microbiome diversity and composition. This is an exploratory analysis. The data for this project was derived from the PASIM study, which is research on access to water in children's health in Mozambique. I will also plug our side session that is happening tomorrow morning at 8:30. I don't know the name of the room, but thank you, Azalea. It is the first big reveal of the results of this intervention study. So encourage you all to come. There's going to be some interesting stuff. But the overall goal of this study was to test if and how improvements in water supply in Beira, Mozambique impacted child gut health, including gut microbiome composition. So the PASIM study employed a matched control cohort design following mother-child dyads from late pregnancy through children 12 months of age. And these study included activities such as eligibility assessment and consent, a visit survey where we got questions, asked questions about the mother, the child, and drinking water. This is a very comprehensive slide about all the activities we did, so I'll focus on the data that's important for this research. We took source and stored water samples and assessed for fecal indicator bacteria, turbidity, chlorine, and piped water flow rate from the source. We measured child growth, which isn't relevant here. And we also collected stool from the children to assess for parasitology, enteric infections, and the gut microbiome. And then dried blood spots, which also isn't relevant here. So, oh, this isn't working. There we go. This was a longitudinal study where we conducted all of these activities across visits from baseline or at enrollment, when the mother was pregnant, through the end-line visit or end of follow-up, which I'll call it is the 12-month child visit. And that's what we'll be focusing on today. This is a cross-sectional exploratory analysis at the 12-month visit only, but we do have longitudinal microbiome data, and that analysis is forthcoming. So water quality and access was measured in a variety of different ways, and I might speed through this a little bit, so please feel free to ask me questions after. We measured the prevalence of any E. coli in source water and in stored water, measured by IDEX. We assessed prevalence of access to basic water defined by the JMP water service ladder, access to water on the premises, access to sufficient quantities of water when needed. That was respondent reported, as was the access variables. We assessed water insecurity using the HWISE index. A score of greater than 12 was deemed to be water insecure. We measured free chlorine and categorized this by the prevalence of households that had the WHO recommended levels of free chlorine between 0.2 and 0.5 milligrams per liter. We measured piped water flow rate and categorized that by greater than or equal to or less than the median flow rate for across all households. We asked households about their satisfaction with water pressure, and we also measured a subset of stored water samples for enteric pathogens. So there's only 51 samples here compared to our much larger study, but these results we thought would be interesting. So before I talk about methods, for those of you who are unfamiliar, I'm going to do a quick overview on alpha and beta diversity, since I'll be using those terms a lot. When I say alpha diversity, I'm referring to the within sample diversity of a single child or a single sample. So in this tree picture, within community 1. And when I talk about beta diversity, it's comparing the total community composition between two samples or between two children. So comparing the structure and composition of community 2 to community 1. So with that said, we measured alpha diversity using Shannon's Diversity Index, which is a measure of species richness and evenness, and this is a continuous outcome for each child, so we're able to model this as we would with any other continuous outcome using multivariate linear regression models. Beta diversity is a matrix. It's comparing whole communities. So we aren't able to model this in the same way. We did use 2 measures of beta diversity, weighted and unweighted unifract distance, and I can explain later what those mean, and ran Adonis 2 models to do Permanova significance testing to see whether or not each exposure measure was associated with total community composition. We also tested for differentially abundant individual bacteria genera using the Maslin-2 package, which employs log linear models, and corrected for multiple association testing. So our results. I wanted to show this exposure frequency table. Most of it you don't have to worry about taking in, but I did want to highlight that the prevalence of any E. coli in source water in this community was actually fairly low, which may not make sense while I'm presenting this now, but you'll see later that this has some implications for some of our findings. So this forest plot showing the association between drinking water quality and access and alpha diversity. And I want to just point out, rather than walking through each individual outcome, that you can see the point estimates bounce from the right to the left, all hovering around the null beta coefficient of 0. There's no clear pattern of association between any of these variables and total diversity within a child. Although we do see a large effect estimate, though it's imprecise, probably because of our low sample size, for the prevalence of any bacteria or protozoa in stored water, we see that there might be some signal, though imprecise, with a lower diversity associated with bacteria in water. So this table is showing the Permanova results from the weighted unifract distance, which tells us something about differences in common taxa in the gut. And we see that any E. coli in source water, access to water on the premises, and water insecurity are all associated with changes in community composition defined by weighted unifract distance. And water on the premises, access to sufficient quantities of water, free chlorine, and satisfaction with water pressure were associated with community composition or changes in community composition defined by unweighted unifract distance, which tells us something about the presence or absence of rare taxa in the gut. The results from our feature-wise association testing show us all these different genera that were differentially abundant by these water quality and access variables, and I don't have time to walk through all of them, but in large part there's compiling evidence or compounding evidence that these findings support that there's improved water quality and access supports the development of healthy taxa in the gut. So for example, ureaplasma was depleted among children who had access to basic water, and enriched ureaplasma has previously been associated with increased risk of infant mortality, so depletion is good. So what do these findings mean? Our summary findings first: no association between water quality and access and alpha diversity. Water access was most consistently associated with total community composition or beta diversity and differentially abundant taxa. Source but not stored microbial water quality had minor impacts on beta diversity. And there's some evidence that improved water quality and access supports colonization of healthy taxa in the gut. So what does all this mean, and why did we find these findings? First, I mentioned at the beginning, 12 months is a highly transitional period during gut microbiome development. So our cross-sectional study might not be enough to elucidate the mechanisms or the pathways between these exposures and outcomes. Or hopefully our longitudinal analysis from 3, 6, and 9 months will provide more insight. At this age, other exposures might be more important, particularly in this population. So enteric pathogens, antibiotic exposures, and child diet. Water quality data, as most of us in the room know, is noisy. So a snapshot at one point in time cannot capture a child's true exposure to water. And children in the study reported consuming, or their parents reported giving their child other sources of drinking water. So at the beginning I mentioned the water quality was relatively good, and so water might not be a major determinant of the microbiome in this context. And water access, defined by these two variables, appears to be more associated with water quality more associated with the gut microbiome than water quality measured by fecal indicator bacteria, maybe implying that increasing water access is infecting the gut through other pathways such as food hygiene, increased water intake, and others. So we'll end there and stop for questions. And I didn't put my email.
Right, thanks, Courtney.
Yeah.
Any questions? Okay, simple. Do you have a question?
Awesome talk.
Thank you.
Did you consider including breastfeeding patterns into consideration?
Yeah, that's a really good question. We do have breastfeeding data. Unfortunately, we don't have any other diet data really. But at this time point, the majority of children were not being exclusively breastfed, so we can control for it, but I don't think it is impacting this relationship.
Hi, just a follow-up. A lot of great information, a lot to
Yeah.
digest quickly, but
Sorry.
just along the same lines, you looked at water access and those that had water nearby
Yes.
had different outcomes. That could be associated with how urban the population is, could be associated with wealth, socioeconomic status. So I'm just curious, what did you control for in your
Yes.
analysis?
Yeah, I
As well
did.
as food access to different kinds of food, et cetera.
Speaking of a lot of things to throw at you all, since these were all different, I don't know if this is actually going to work. I did have a summary side in here about covariates, and went through each kind of exposure outcome relationship and thought about a priori, identified a list of confounders for each model. So we did control in almost all cases for socioeconomic status and education of the primary caregiver, but in other cases we controlled for other variables, even within the water quality and access exposure variables that might be associated. I apologize, I'm having trouble getting to that slide. But yeah, we do have, we did think through those relationships and potential confounders and included those in those models.
Really nice presentation and really fascinating data set to look at this. And sorry if I missed it. What were like the water source types? Were these mainly piped water supplies? Did you have
Yes.
like variation? Because I'm just thinking about the types of water. Like E. coli is like a measure of like fecal contamination. But when I think of microbial communities and different types of source water, thinking strategically about okay, what variation around kind of water sources.
Yes.
Yeah.
Yeah, great question, and we'll talk a lot more about water source tomorrow in the side session. The majority of children here were using a pipe drinking water source, whether they had access on the premises, were purchasing from a neighbor, or were using a public standpipe. So it was primarily piped drinking water.
Great presentation.
Thank you.
I'm really excited about the longitudinal data.
Yeah. Yeah.
I don't know if you mentioned this, but what were the chlorine residual levels that you were measuring? Did you present
The only thing, I didn't look at like chlorine residual as a continuous outcome. We just kind of created that binary variable. So if the free chlorine residual in source water fell between 0.2 and 0.5 milligrams per liter.
Why not allow a little bit more of a larger interval there?
Yeah.
Because 0.5 is pretty
Yep.
low still.
We can. I will be completely honest that this classification of free chlorine was in our protocol paper. This is how we were going to use it for the other parts of the study. So I was trying to maintain consistency, but it's definitely something that we can look into. Yeah, absolutely.
I can say, I had a question about, the first question was the sample size. What was the sample size
Yes.
that you had?
Yes, great question. It was 548 children.
And it was 16S to
Yes,
something that you
yes.
did. And when you were looking at the commensal microbes, I think it would be really interesting to do metagenomic sequencing so you can see the species.
Yes, yeah.
And maybe even for like things like Akkermansia, look at like the strain level and see
Yep.
what you have there. Is there a plan for that?
If someone wants to give us a bunch of money to do it, we have all of these samples. We have banked samples that we can go back and then test. So that is the hope, is that some of these preliminary findings and data, we're seeing some of these interesting things, and that can be used to get more money to do metagenomics.
Particularly for the Akkermansia, since the literature showing it's associated with a child broke, that could be
Yes.
a really important one to focus attention.
Definitely, and I didn't get to talk about it, but in the study in Bangladesh where they looked at water chlorination, they saw the same patterns with chlorine that we did, where it led to like a depletion or enrichment. I don't remember what it was, but we are seeing that across multiple studies now in these children, again, at that highly dynamic time. So it appears that there is some signal there that is worth exploring.
But for some of these commensal microbes, you can just use qPCR and look at them. You don't have to do metagenomic sequencing. So
Yep.
is there a plan for that?
Money,
Okay.
yeah. Yeah, hopefully. I think there's enough interesting stuff here, and again, with the longitudinal data, hopefully it'll be good enough that someone will give us some money to do that.
Really interesting findings, thank you.
Yeah, thank you.
Any more questions for Courtney? Last one, yes.
Hi, wonderful question. So you look into the relationship between the prevalence of E. coli in the water and the alpha diversity. The current alpha diversity is based on the genus level, microbiome facility. Do you think you see the difference between the strains?
Yeah, so the question for those of you who are online or didn't hear was about looking at alpha diversity, the relationship between E. coli in water and alpha diversity, and about looking at the genus level. So I should say alpha diversity was calculated on the amplicon sequence variant level. We just can't identify what those species are, so when we're presenting the differentially abundant features, those taxa, we aggregate up to the genus level so that we can actually say something and learn about what that is. Otherwise, it would just say ASV 132. So the diversity metrics were calculated on the amplicon sequence variants, or OTU level. Yeah.
Okay, over to Heather once again.
Thank you very much.
Thanks everyone for still being here. I'm really excited to talk about this trial I've been working on for a long time in Pennsylvania. So it's called the Wells and Enteric Disease Transmission Trial, and I've got some preliminary results from our pilot to share with you today. But first I want to start by sharing my amazing team of people that I get to work with, and I really want to acknowledge Debbie Lee, who's in the top left corner, who was our trial manager for the pilot, and now she's a faculty member, and then Kristen, who's our current trial manager, and then Jeff, who's a former trial manager. So a lot of people who have contributed to this work. So what is the burden of disease attributed to private wells? This is my $1 million question that I've been chasing. So there's no robust estimates that exist. There's a handful of population-based studies that look at AGI and private wells. And some work that I did a long time ago when I was at the Public Health Agency of Canada, we crudely estimated using microbial risk assessment that there's around 70,000 cases of GI illness per year due to private wells in Canada. Now, if we extrapolate that to the US, that's like 1.3 million cases annually, which is a substantial burden potentially. So where are these illnesses coming from? Well, there's fecal contamination that makes its way into well water. So sources is often agricultural activity and septic systems. So this is a newspaper article from my colleagues' work in Wisconsin, where they looked and traced back contaminants to dairy manure and septic waste when they were looking for contamination in well water. And so today, no one has actually done a RCT, or randomized control trial, to look at illness attributed to private wells. And so I set out to try and do so. And so we have the WET trial. And to give you an idea of the timeline of how long I've been tracing my dream is starting in 2018, I got a grant to plan the trial. And then we moved and got a pilot in the beginning of the pandemic, which was excellent timing to start a pilot trial. And then we got funded with the full trial, which is ongoing to this day. So the Wells and Enteric Disease Transmission Trial is the first trial to look at the impact of drinking untreated private well water on GI illness. And we're comparing whole home UV water treatment device to a sham device. So essentially everyone in the trial gets a whole home UV device. Some of them are active and some of them are inactive. And we're focused on children under the age of 5 in Pennsylvania, and also now New Jersey. We've expanded a little bit. And so we have 3 scientific aims. The first is to quantify the disease reduction in terms of acute gastrointestinal illness and respiratory illnesses. And so that's self-reported or parent-reported illness data that we're collecting. The second is to compare child stool samples between the control and UV groups. So do we see a difference in what organisms the kids are being colonized with, whether they're drinking treated or untreated water? And then also to compare pathogens we find in the control well water with child stool samples in the control group. So do we find pathogens in their well water, and do those correspond with the pathogens we find in the children? So we're doing this study in Pennsylvania, which is in the northeastern part of the United States. And so why are we doing it? Well, I worked at Temple University, which is in Philadelphia, so it was highly convenient for me. But scientifically speaking, it's actually a good state to do this work because it has the second highest number of private wells in the United States, second to Michigan, and a high density and a wide diversity of geology to study. So for the trial, the eligibility requirements at the household level, they have to rely on a private well. They have to have no water treatment capable of removing microorganisms. They have to reside in southeastern Pennsylvania and now New Jersey. The child has to be under 5 years old at the end of the study period, meaning they have to be enrolled before they're 4 years old for a 12-month follow-up. They have to drink at least 1 cup of untreated well water daily. And they can't have any underlying health conditions that can interfere with our outcome of interest, so GI illness. So our goal for the full trial was to recruit 908 participants, our households with children under 5, half randomized to this whole home UV treatment device, so it looks just like that installed, and then half to a sham device, which looks identical, but it's not functional. And the children are followed for 1 year. And so essentially every week the parent of the child gets a text message that says, in the last week, did your child have any of these symptoms? And if it's a yes, they then go to a detailed illness questionnaire. And if it's a no, they're done for the week. And so we're comparing the gastrointestinal and respiratory illness symptoms between these 2 groups. And so our illness data collection, we call it novel text message based, but I don't think that's novel anymore. We have a greater than 98% response rate so far, which is amazing. And so we're hoping it's going to reduce recall bias. And so we have this kind of innovative calendar function where we tell the parent, okay, think back from this day, 7 days prior, and we collect the symptom data daily. So every single day we collect detailed symptom data, and then we code it into our outcome variables. We also have a sub-cohort of households that submit stool samples and water samples during symptomatic cases and also during no symptoms at all. And then we collect water samples from a subset, and for our pilot, everyone we collect water samples from. So we had 28 homes in our pilot, and the full subset group is 150 homes. And so we collect a 1 liter grab sample, and we analyze that at Temple for total coliforms, E. coli, enterococcus, and physicochemical analysis. And then we collect stool and large volume ultrafilter samples that are collected on site. So we filter 800 liters of water, and those samples are sent to our colleagues in Wisconsin at the USDA, and they analyze for a suite of pathogens. Oops. So our pilot trial results. So our pilot happened in COVID. So the results are actually kind of interesting. We had 28 children, 50% female, 13 in our sham group, 15 in the active. All completed the study for 12 months, no dropout. Our baseline characteristics were balanced by age, race, parent education, income, daycare attendance, breastfeeding. I was going to skip these because I run out of time. Okay. And then we did assess blinding. So we did it 2 different ways. One, we used a blinding index to see whether or not we were successfully blinded. So basically 1 is perfect blinding, and anything greater than 0.5 is considered successful. And so we were 0.67, so our participants were successfully blinded. We also measured it another way where if you're close to 0, when we measure in each arm, it means that the blinding was successful. So we were also successful in that aspect. Now looking at GI illness, I'm going to present several different outcome variables that we looked at. And so we looked at it by day because we collected the symptom data by day. So usually we say within the last 24 hours, what are your symptoms? So we coded GI 1 day and GI 2 day to represent 1 calendar day and 2 calendar days, which could conceivably be 24 hours depending on the timing. So it was 3 or more loose stools or 1 vomiting episode in a calendar day. And so we saw greater cases in the sham group slightly, so these are incidence rates of cases per person per year. For our GI 2 day, you can see we saw also an increase in our sham group versus our active group. And then we looked at a couple other GI definitions that are a little bit to be in line with other water treatment trials that have been done globally. There was one done in Australia, and they used this kind of looser definition of GI illness. So 2 or more loose stools, or 2 or more vomiting episodes, or 1 loose stool and 1 vomiting over a calendar day. So when we looked at this GI illness definition, we did see an increase in our sham compared to our active. And actually over 2 days, it was statistically significant, which was super interesting given we only had 28 kids and we powered the study over a large population. We think this could have been because of COVID, and there was very little illness circulating, and it's possible that the illness we found was actually due to the well water. We also looked at acute respiratory illness, and so we did see an increase in ARI in the sham and compared to the active group. And in terms of our sample results, our stool samples, we collected 95. You can see 62 in the absence of symptoms, that's because kids weren't sick, 12 in the presence of GI, and 12 in the presence of ARI symptoms. And unfortunately, no matter what their symptoms were, we didn't seem to find a relationship with pathogen presence, which I don't think surprises many people in this room. So we found 15% positive for adenovirus, 2% for norovirus G2, 2% for Shiga toxin 1 gene, 1% crypto, and 1% enteropathogenic E. coli. For our water samples, just for the fecal indicators, we had 96% of wells were positive for total coliforms, 46% for E. coli, and 29% for enterococcus, such as contaminated wells. And you can see pretty high concentrations. Lastly, our ultrafilter samples, we had 93 ultrafilters that we analyzed, and we detected Salmonella, norovirus G2, rotavirus A, and Cryptosporidium, as well as human Bacteroides, which is a human sewage marker. And I just want to point out that HUM2 and HF1E3 columns, those are the human sewage markers. So you can see between 14 and 29% of wells were positive for human sewage. So from our pilot, what have we learned so far? Well, we've learned that fecal contamination making its way in the well water. We're not entirely sure if well water is contributing to GI illness, but our preliminary results are suggesting possibly so. The next steps is our full trial, which is ongoing. So we're 550 of our 900 participants enrolled. Yes! And we have had like hardly any dropouts, so we think we're going to get away with 800 people and hope to have them all installed a year from now. And so I'd like to thank all the people who funded this research and our advisory panel of experts, and with that, and our families that have put up with us bothering them over the years. I'll take any questions.
I see 2 hands anymore. Right.
Very interesting presentation. I have a question about potential ethical concerns with the sham filter, given that 46% of the wells had E. coli.
Yeah, that's
So I just want to understand better how that's being addressed in the randomized control trial.
Yeah, that's a good question. So we don't take any preliminary water quality testing. We only take it later on, and then in our informed consent process, we tell them that we'll give them their results at the end of the study and that they may have contaminated water, but we don't. And this was all approved by our IRB, so they're aware. A lot of them believe they're going to be on the active, and so they're willing. They can't afford maybe a treatment system, so they're like, well, I'll take a 1 year without any treatment, and then at the end of the study, everyone gets a full treatment device. I didn't say that, so everyone gets a full active device at the end of the study period. Yes.
Thank you.
Can I use my powers to ask?
Yes.
Before the experiments or before the pilots, were they giving the children 1 cup of water or more?
No. So they're consuming 1 cup of water every single day. Like they have to. Well, that's what they have to report that they consume to be eligible for the study. So there are kids drinking well water every single day, and then they're enrolled in the study. Yeah, basically, yeah.
Hi, just wondering, were you able to isolate for any other water sources? For example, bottled water or water coming from the outside. Was there any form of isolating the control group from that, or?
That's a good question. You mean was there any other water consumption happening?
Yes.
Yeah, so no, we can't control for that. That's the idea of hopefully the randomized control trial. That external consumption is equally distributed between the 2 groups, and the groups are identical except for the intervention. At least that's if our randomization is successful. However, we do have an installer that goes in and checks for bottled water and checks for treatment devices and makes sure we have adherence. So every month we lose like 5 potentially eligible people because they have a treatment system in their home that they didn't know about or didn't tell us about. So that's a good question.
Hi, thanks. I'm Rachel Peltz with the Quiet Institute. Thank you. This is fascinating, Heather. I wanted to ask just about your baseline incident. You skipped over that pretty quickly.
Yeah, sorry.
But no, it's okay. I think it was 2 or 3 per year in your pilot. And I'm also curious if in the full trial, if you know yet, if you're seeing different numbers now that it's not COVID.
Oh, in terms of the cases?
Yeah.
Yes, they're much more elevated. So we're up to like 2 cases of GI illness on average per kid compared to the pilot, which was more like 0.9, I think. So a lot more. We're in the process of doing an interim analysis of our like 400 people that are basically completed at this point. So yeah, we're going to try and see where we're at. But yeah, the cases are much, much higher in line with what we powered the study based off of. Yeah.
I have a question. So in one of your slides, you said that you're analyzing chemical contaminants. So are you only analyzing microbiological contaminants, or?
Yeah, we're only analyzing for microbes, but we do analyze for a suite of parameters at installation of parameters that could affect the performance of the UV light. So we look at iron, manganese, dissolved solids, conductivity, pH, turbidity. We also do some of that analysis in the lab when we collect water samples, just general water quality. Yeah.
Now that you've included New Jersey, are you looking at arsenic? Is there any plan to look at arsenic?
No, we're not. But if we find, so back to your ethical questions, we do avoid areas with known PFAS contamination. If people know that they're in an area of high risk and they start asking us about those questions, we ask them to talk to their health department before we enroll them in the study. Yeah.
And is there a standard message given, let's say to both arms, on saying boiling water is good to address microbial contamination, some type of standard message, is that given in both arms?
No, there's no standard messages given into any arms, no.
That's the first one.
Oh, thank you. So I was curious, did you measure the depth of the well, and how does the depth of the well kind of like plays an impact in terms of the quality of the well water in general?
Yeah, that's a great question. So a lot of these homes don't have great records of the depths of their wells, but if they have well, upon installation, we get their well records. So if they have a printed record, or we try and pull those records, so sometimes we know the depth, sometimes we don't. In my other research in Pennsylvania, yeah, there's sometimes even dug wells, like really shallow, as well as really drilled wells that go down like 700 feet. So it kind of depends, but we've seen contamination in both types of wells. And the geology in Pennsylvania, there's a lot of fractured rock, which allows for rapid transport of pathogens in the environment. Yeah.
Just to prove that I was paying attention earlier. I mean, just following up on that question about like how many are in the karst area versus non-karst, and I'm also curious about fracking and whether you're sort of keeping track of that.
That's a good question. We haven't been tracking fracking. In terms of that middle area of karst, we're not in there. I kind of wish I was over there, but it's so far away from Philadelphia. So we definitely have pockets of ribbons of karst in our area, but we're not in that swath that I showed in my presentation. And I don't have a map, but we have a spatial map of where they're distributed, and we will do some kind of spatial analysis looking at land factors and geology associated with our water quality and our kids' stool samples. Yeah.
And actually, I'm also curious just about the reporting. Are you still getting that 98%?
We are. We are getting a crazy response rate. It's really, and we have had hardly any dropout. We do follow up with them, so they get a text, then they get a reminder text, and then if they don't get back to us, then they get a phone call, and they get an email. So after all that, we get the response. But it's usually like 10 offenders a week. It's the same people that my trial manager's like, oh, I gotta call them again. Yeah, they're just busy parents with young kids. Yeah. So. Mm-hmm.
Just one more question. So, are you still, even with like the updated trials, are you still getting the high percentage of total coliform and E. coli? Like,
yeah, actually, I did look at that. The full trial data, we do have that. It's still extremely high. Yeah, it's still in that same ballpark in our full trial participants. Yeah.
So the houses that the families enrolled, do they have septic tanks?
Yes. Not all of them, but most of them have a septic tank, yeah. Some of them are on a public sewer. There's kind of a mishmash in Pennsylvania.
Was there a difference in results of water contamination between septic tanks, the houses?
Yeah, that's a good question. We haven't done that analysis, yeah.
Thank you.
We have a little time, we've got 2 questions back here.
Great presentation, I'm really excited to see the results. You mentioned one of the criteria is 1 cup of well water per day. I wonder if you collect the data on how much, how many cups of water? Is there any possibility of looking at those response?
Yeah, we could, but we're not entirely confident that they're going to report accurately, and we wanted to make it less burdensome, so that's why we think we don't have, we're not asking them too much. We don't collect that much data from them, so then they are more likely to respond, but it's a good question. That's our eligibility requirement, so, but we're treating all the water in the home, which is a bit different than some prior studies. So like even teeth brushing, bath water, all of that gets treated. So we're hoping from that dose response perspective, we're treating and might see an effect. Yeah.
Hi again.
Yes.
Way back here. Yeah, so in the spirit of turning research into practice, what do you plan to do with this data afterwards?
That's an excellent question. I plan to use it to try and restart the conversation that private wells are a problem, which has been talked about since the 1980s. But I don't think anyone's had any data to support like people are actually getting sick. I think there's enough out there to convince people that people might be getting sick, but then to kind of take it to the next level. We're already working with pediatricians in the state of Pennsylvania, and so we've done webinars and outreach with them to talk to their families, and so that's where we'll go next. Yeah. But thank you, that was a great question.
Right, thank you so much, Heather. That was a good wrap up. So I just wanted to use this opportunity to thank Heather, Kelly, Courtney for your presentations, and to say enjoy the rest of the evening and also enjoy the dinner. Thank you very much.
Yeah. Sorry, we left you so much
Love to
time.
talk about this trial.
Well, yeah, I'm glad you ended on this one. I actually also have a question, but I figured I'd just ask.
Oh, we're using Qualtrics. Qualtrics Twilio. Yeah. Your staff, so cool. Debbie, you know Debbie.
Yes.
Yeah, so we have a failed grant submission, taking the trial data and looking at that microbiome. And we were going to recruit new kids in Canada.
So I think we're having other problems. What I've seen is like that's the primary goal of the study. They're like, no, but if you're like, we also are going to do this, they're more interested. But I think it's so hard. I've realized, because I also just got microbiome for the intervention tomorrow. Like, what do you do with that? What does that mean? And especially like here, we actually know a lot more, so I'm surprised to hear that before.
Because we were going to compare the two groups, so Lisa, you can say that there's a difference between treated versus untreated.
Right.
And if you need another citation, the American Gut Project found that private well water was a signature. We use that one all the time.
There's like the drinking water type, and they have Wells bottle in each city or something. Yeah, I've seen that one. I don't know that maybe they broke their data out by children.
But there's more stuff coming on. There's an early life exposure researcher at University of Washington that is doing water in all exposures, like doing the gut viral and gut microbiome.
Cool.
She's on our advisory panel.
What's her name?
Lori Holtz.
Okay.
And then
sure
Phil Tarr, he's a co-author on one of the papers you showed him. He's on mine too, and so we've been trying to get something funded.
We
have some pilot data.
There's lots of cool stuff, and it's also becoming more feasible now to like scale it up. And the epi methods are still catching up, though, which is a big passion of mine. Is like bringing epi to this like bioinformatics stuff.
Yeah, that's great.
Good job.
Thank you.
We're doing a lot of bioinformatics work. Like Joe Brown. I am. Nobody else in my life.
Are you doing metagenomics, amplicon sequence?
I think so. We just took baseline data, like baseline, samples, and we're going to be doing amplicon with those. But our partners are culturing. So we're specifically interested in AMR, like bacteria, and looking for ARGs within them. And we're specifically looking at these like escapee pathogens. Okay. Oh my God.
That was
familiar.
the poster, the Emory's poster that Karen did, and that'll be like my postdoc I'll be doing some AMR.
Amazing, yes. So we're doing that, and then like our partners in Bolivia are culturing up those escaping pathogens, and we'll be shotgunning those. Yeah.
Yeah.
Good
Good
job.
luck learning it all. It was like I had never done any of it, and so like jumping.
I went to a course. You're probably yes.
Yeah. Did you do this summer?
Yeah.
Okay, I went last summer.
With Ben Callahan.
Yeah.
And
Yeah.
Titus.
You'll see.
Titus.
Maybe it's not in here, but I like totally stole their slides on explaining weighted and unweighted.
You're doing your postdoc with Karen?
No, Maya not actually at Emory. She does antimicrobial resistance, mostly in animal, like food and animal context. So Matt is going to be tangentially involved. She's got some like informal market studies and like antimicrobial resistance transfer from like risks at those informal markets to kids because we know there's pathogen risks.
Okay, so do you know Olivia Ginn?
I know the name.
Okay, so she's not like super into AMR necessarily. It's more so viruses.
Yeah.
But it's like very, very simple. I mean, it's like zoonotic period. But like we went out to, her and I went out to like this literal like cow town in Bolivia, and we took all these samples, and we were going to try and find. I was going to try. She's more so interested in the viruses.
Yeah.
I'm more so looking. I like have all these samples to look at the like the microbes out there that could potentially be like AMR, and so then potentially like they're being passed from animal to
that's what. So like there's a current PhD student who's working with Maya who's doing like the strange strains of E. coli between kids and chickens.
Where?